There you go. So for the last 4 years of my life, I've spent a chunk of my time working on the American Academies evidence-based review for sports-related concussion clinical management guidelines. And so I'm not going to be able to go through everything in that covered in those 4 years. What I'm going to go over with you is a little bit of how we did that. I'm very briefly going to talk about the findings. They're all going to be in the slides, which you can see, which is a summary of the document, which you can also see. And then I want to talk a little bit about maybe some of the surprises or some of the things that we found that were different from other consensus-based guidelines. One of the important things with this was that it was a multidisciplinary effort right from the start. So although it was driven by the American Academy of Neurology, neurologists were in a minority on the Committee of 12, and multiple organizations have endorsed it, not only medical organizations, but athletic trainers, coaching organizations, and school organizations. The development process is rooted in the fact that there's been a lot of concern about sports concussions, both from a research standpoint and in the general public, but also a lot of misconceptions out there, and often predictions among physicians, and researchers that exceed what the data is. A number of very good consensus-based documents that are out there already. Consensus-based documents always run the risk of having bias or having undue influence from commanding personalities on the committees and things like that. The evidence-based guideline was intended to try to objectively review the data as much as possible, and hopefully you'll see in our process. And there will be limitations to that approach also, because there will be certain things that evidence-based medicine won't be able to reach, including things that happen with very rare occurrence. But our process began with clinical questions. We arrived at, with the help of an evidence-based medicine expert, Dr. Gary Gronseth, 4 clinical questions that we thought were important, and I'll tell you what those are. We then reviewed the literature through a systematic lit search. Some of that I think you guys are going through, rated the papers. I'll show you the numbers that we reviewed, and we classified evidence and put it into evidence tables. Again, all available as an appendix online. From that evidence, we then developed conclusions, and through a modified Delphi process, turned those conclusions into clinically actionable recommendations. Okay? And one important concept, some of this is redundant, but one important concept was during the process of developing this, in 2011, the AAN updated its process for developing evidence-based guidelines to be more consistent with the guidelines recommended by the Institute of Medicine, and those were not available back in 2004, which were the process that we were following from the beginning. Each abstract was reviewed independently by 2 authors on the panel, and if there was not consensus, then a third was brought in for a tiebreaker for each one. So that was quite time-consuming. Then this process you may be familiar with from the perspective of the chair, who has some opinions, or co-chair. One of the aspects of this sort of modified Delphi process was that once you reviewed data, you rated that data into a recommendation in terms of, is this something that is helpful? Are there unforeseen side effects of this? Is it effective? Is there infrastructure out there to implement this recommendation? Those are all part of the way we arrived at the recommendations, was done anonymously through a web-based interface, so that you could put your reasons there, and people could see those reasons anonymously at each round of the recommendation development, but there wasn't the opportunity for any single personality to sort of dominate the live discussion. And I found that to be and also disempowering as committee chair, but then that kept us closer to what the evidence really was. What did we consider in developing these? Well, the primary data source are published peer-reviewed studies directly related to the clinical questions. Okay, and means our clinical questions were the management and assessment of sports-related concussion. Okay, and so what it means is mild TBI is a little bit different. Here, moderate to severe TBI is different. Things that are not captured in sport were also different. Okay, primary data pool is what's there for sports-related concussions, again, and we included both youth and adult. There were studies, and we touched on some of these, where mild TBI was the parameter. They were not part of the primary literature search, but they were used in a couple of scenarios, particularly for neuroimaging and cognitive restructuring, where there was significant data in the mild TBI field that wasn't specifically done for sports concussion. And then there are some axiomatic principles which are things you would never have a randomized control trial, but as an example, for if you were to an analgesic for a headache, it would be considered axiomatic that taking that medication might mask the symptom of headache. Okay, and you didn't need a study to prove that. What's also important is what was not considered. Okay, expert opinion didn't really matter. Okay, consensus opinion also wasn't really part of this. Importantly, case reports and case series are Class 4 evidence and were therefore excluded from consideration. Okay, analyses, review articles were noted. We searched them to make sure we weren't missing any primary literature, but review articles and meta-analyses were not part of the evidence-based review. And then lastly, I'd say this with some, willfulness as a laboratory scientist part of the time, but basic science also not included in the clinical guideline. Evidence was rated based on the likelihood and highly likely or high confidence in the data, moderate, low, or whenever we say insufficient evidence means there was very low confidence in the data, meaning either there wasn't data or that there was conflicting data, even if there were good studies. And you have the evidence, you have a level of obligation to the recommendation. So this is all process, but it's just hopefully to understand. So if there was something that we felt that must be done, that's a level A recommendation. That's actually quite rare in the setting of not having Class 1 data, randomized controlled trials. Level B are strong recommendations, and C are weak. 4 clinical questions. The first one is, for athletes, what factors increase or decrease concussion risk? Okay, and I'll mention actually in Dr. McAllister's presentation about the genotype. For example, the subtle thing mixed in there is that some of the studies looked at the genetic risk for complications of concussion. Other studies looked at the risk related to having a concussion in the first place. Those are 2 different outcomes. So here we separated them. First question is just what more or less likely for you to get a concussion? You can see the numbers. You probably are facing some of these challenges also. This question was for athletes who were suspected of having a concussion. So we're not sure yet. Something happened to them and you think they might have had a concussion. What diagnostic tools help you determine that they did or did not have a concussion? Okay. And related to that is for athletes suspected of having a concussion, what diagnostic tools were able to predict whether or not they had more severe, sort of early impairments within the first days or weeks, versus neurological catastrophe, okay, chronic neurobehavioral impairment, so things that were lasting weeks or months after the injury. And again, these are 2 slightly different questions also, but focused on diagnostic tools. The third question is, the diagnosis is over. Concussion diagnosis is made. In most cases, it's done clinically. What factors are useful to identify those who had increased risk, again, for the most severe early presentation, neurological catastrophe, chronic behavioral impairment, and then we added in here also what clinical factors associated with the risk for repeat concussion. Okay, that inherently is something I think that sports-related concussion a little bit different from mild TBI is the expectation that you would go back and assume the risk of the mild injury. Whereas if you fall, kids fall, but it's not necessarily expected that you would go back to that. You're going to be admonished actually to be careful. And this one, which is perhaps everybody's most interested in, and of course the least data, is for athletes with a diagnosed concussion, what interventions make things better? And we looked at it several different ways. Does it help you get better early? Does it reduce your risk of a recurrent concussion or diminish long-term sequelae? So the was reviewed. It's all in the document. We came up then with 3 scenarios where there were recommendations that were actionable. Okay, and one was pre-participation counseling. So I'm going to go through all this in detail. What I'm telling you is these are the recommendations in a summary fashion from the evidence-based guideline. I tried to make them a little easier to look at here. I put asterisks next to each data, which there were athletes under the age of 18 that were part of that recommendation to hopefully make it better. And where possible, I would indicate also the class of the studies, but the full evidence tables you can look at. So we learned things that we knew. We knew certain sports had high risk. We learned things that maybe we didn't know well. For sports that were comparable, in particular soccer and basketball, girls actually had a higher risk than boys. So it's not just boys' injury. We learned, and this comes up later also, concussion risk increased after having prior concussions. So if you've had a concussion, your risk of getting another one is increased. Many in the media that may or may not have influence actually were not shown to have any influence in concussion risk. So the recommendations that were people had to learn these factors and relate them to the athlete, and that was a relatively strong recommendation. For acute assessment management, again, I'm not going to really have time to go over all of the details, but one thing we learned was that diagnostic tools were validated for sports-related concussion in older adolescents and young adults. In kids, not so much. This was actually published after the Guidelines research was closed, but this was just published a month ago, the SCAT-3, where they use graded symptom checklists, they use standardized assessment of concussion, they use the balance error scoring system, all validated in older ages. They don't have forms for child report and parent report. They've modified the neurologic assessment for children, but just remember that now this is a new proposal. There's no sensitivity and specificity data for this type of assessment in kids. It's a step forward, but 5 years behind what's happening for the older ones. So at this point, it remains a clinical diagnosis, which includes all the things necessary for other clinical diagnoses: history, physical, neuro exam, cognitive examination is important. A special caveat for youth concussions is be cautious with these unvalidated tools in the pediatric age range. And we didn't go through the list. I mean, every day there are more tests that are online, but it is the responsibility of the clinical provider to be aware of the tools that they're using, whether or not they've been validated. Most have not, okay? Another important thing, which is relevant for all concussions, youth or adult, is the idea. You notice that although we had a pretty strong recommendation, there were 20 or 30 studies, but they were mostly class 3, and this comes from a fundamental flaw in much of the concussion literature, is it compares clinically diagnosed concussion from no concussion, okay? And should there be an orthopedic control group, as we've heard earlier, okay? One of the other things that would be important, although we didn't find any studies to that effect, were that we're always faced in clinic with patients who come to us with did they have a concussion? Is it an under concussion? And then you determine, was it yes or no? So a study that would look at that group that presents with possible concussion and then helps you determine whether or not the diagnostic test can segregate them into definite or not. That's completely lacking. In studies, there were none specifically with sport-related concussion. Extensive literature from the P. Carn group, Kupperman et al. You guys have reviewed those probably. Mild TBI in the pediatric ER. We did use that mild TBI data to support that CT scanning. It's not recommended to diagnose concussion, but only if you suspect something other than concussion. A whole list of different risk factors that come out. Okay, so these clinical risk factors for either worse acute symptoms or prolonged recovery. You can read the list. Younger age is one. There are a couple of one studies. These are high school students compared with collegiate students, high school students compared with professionals. Okay. You see with the asterisks, many of these studies did include high school or younger students. Multiple studies that suggest that there's an injury for the risk for repeat injury. Recommendations there are that athletes with suspected concussion should be removed to minimize the risk of repeat concussion and worse symptoms. Okay, and the graded return to play. Again, this is a consensus-based sort of standard in the field, but should not be started until symptoms have resolved, and then with that axiomatic principle that I put in there, should be off medications that might affect their symptoms. Covering is another area where there wasn't specific data from sports concussion, but the mild TB literature in both adults and youth suggests that in early reassurance, counseling, not to attribute all symptoms to concussion, and guidance in terms of how to return to activity, cognitive and otherwise, reduce the likelihood of chronic post-concussive symptoms in an analysis of 5 adult studies by about 1 in 7. So about 1 in 7 patients could be prevented from going on to chronic symptoms with just a simple initial intervention. The pediatric studies showed reduced symptom burden at 3 months and reduced family anxiety over the same time period. So it was recommended that that be considered. So that wasn't directly sports-related concussion. We reduced the level of recommendation to level C, even though there were multiple studies. Play and retirement. Again, I mentioned earlier that younger athletes have been shown to recover longer from symptoms. Dr. Gaston has published one of the more recent studies on that. This to also what we heard earlier about the idea of moving toward individualized treatment. So when you're doing symptom management and graded return to play, for which there unfortunately is no objective parameter that, oh, it's 2 weeks or you should return them to play this way. It's really consensus-based. But data suggests that high school students take longer to recover than older athletes, suggests that however you implement those consent-based recommendations, it behooves you to be a little more conservative for the youth athletes. And we don't have comparative data from under high school. I'll mention that in the surprises a little bit. Also, no evidence that complete cessation of activity, very strict cognitive rest speeds recovery. There's class 3 evidence suggesting that moderate levels of activity are optimal. Basic science might also support that. Point is chronic cumulative impairment in professional athletes. Yes, there was evidence in professional athletes of cognitive impairment. I want to make an important distinction here. I'm not talking about CTE. Okay, CTE. There are many definitions, but it seems to at least be associated with the tau pathology. These studies are all clinical studies that relied on reductions in measures of cognitive function. They showed in professional football players, soccer players, boxers, and Giza of all groups. There was some cumulative impairment, and in the professional studies that there seemed to be a dose response, measured in different ways. Some counted concussions, some counted years of playing, but in any case, there seemed to be a dose response, which then again scientifically suggests more of a causal relationship. In youth, there were even more studies that were done. Probably 30 studies met our criteria for inclusion at some level, and in the entering youth levels, however, the results were inconclusive. They were split about 50-50 between studies that found an effect on cognition long-term and studies that did not. This was not an artifact of the studies not finding an effect being underpowered. The number of subjects was actually slightly higher in the studies that didn't find than those that did. And so it's, again, important that, number one, we individualize retirement decisions, and when information is given to families, that it be given based on what the facts are currently in evidence. So what are the differences? What are the surprises or things that we found as part of the process? One, and it was mentioned a little bit today, again, defining what is concussion or mild TBI. This is still a potential issue for research in the field. We did about this for an hour and a half on our first meeting and decided for the purposes of evidence-based review, we didn't really have a choice. We could go back and change the definition that research had already used, so we ended up just repeating what we found. Most of them, or many of the studies, used AAN 1997 guidelines, but many used the physical medicine and rehab recommendations or DOD definitions. Concussion and sport group definition was used in some of the more recent studies. So this is actually, I think, a pressing area for the field going forward to be able to do research, is to be actually that we all call apples apples and oranges oranges. Another thing, again, maybe not surprising to those of us who work in pediatrics, but for those who work in sports medicine in general, I think we're surprised that although there were studies that included concussion down to age 10 or 11, there were no comparative studies under high school. And so our recommendations for being more cautious in youth are based real extrapolation of the high school studies compared to college. A big hole in the research. Higher AAN grading system of trying to determine at the day of the concussion how long that individual would take to recover was abandoned. There's data that has been published since '97 that essentially doesn't support that recommendation. And this may go to our discussion earlier that there are individual factors, and many of the risk factors which we showed you here clinically may be rooted in genetic factors or environmental factors. But the kid who gets knocked unconscious on the field made normal cognitive and balance and symptom-wise within a few days, and kids who've had, sometimes who've hit their head, lock or door can be symptomatic for weeks, and there must be other factors that determine that. The rationale for removal from play, gradual return to play, is not to avoid second impact syndrome. SI we looked for, there was nothing that was above a class 4 case report, and so therefore no incidence or prevalence could be estimated, but there was very strong data that if you had a concussion, that you were more likely to get a concussion. There were some prospective studies that showed that risk for the second concussion might occur within 10 days of the first. Okay. Also some studies that showed that the more concussions you had, your symptomatology was more severe. Probably how to be better. The only intention to improve outcome was the kind of restructuring, gradual return to play, pharmacotherapy, cocoon therapy, cognitive rest, all had insufficient evidence. The rationale for retirement was not to avoid CTE. Again, the CTE evidence was all class 4 case reports. It was to avoid this measurable chronic cognitive impairment, which again, I'll point out, was only seen in the professionals. There's no evidence that will show that this is okay. I think you guys may have seen this before. If you haven't, then okay. So those elements avoided. Lastly, you can find all the documents here at AAN.com concussion. So for your attention.
We are running a little late. If